I'd like to also welcome the PAs, PA students, and nurse practitioners, and social work students. Thank you for participating. This is a crisis that involves a huge portion of our country. And it's going to take everybody working together. No one, physicians aren't going to be able to stand up and stop this. We need the help of everybody. So thank you for all coming. And by the way, since we're in a thanking mode, let me thank a couple people. First of all, I want to thank Dean Kessler. And I want to thank Juhi. To put on something like this, we need some support. And they readily gave support. And I'm sure they're going to get some criticism. I know it's tough all day Friday, all y'all being here. And for some of you, you're going to say, well, I could have learned this. I could have learned this on MediaSite. And, well, am I going to use it? Well, when you start your rotations, you sure will. You'll see. Many of you may already see the impact of opiate addiction, opiate overprescribing, overdose deaths. So I'd like to thank Juhi and Dean Kessler and Dr. Leo. One thing I'd like to get across to everybody is, from what you've seen in the media, what you may have heard, it's worse. When you start actually getting out there practicing seeing patients, you will see it's worse than what you're led to believe. Especially for the PAs, nurse practitioners. Dr. Trzil is the founder of osteopathic medicine. Now, I'm an MD, so I'm not tooting my own horn. But more than 100 years ago, look what Dr. Trzil said. Saw legions of men and women going to and fro. This is what he said. He already saw this. This is from the autobiography of Dr. Trzil, 1897. He already saw the effects of opium overuse, opium at the time mostly. Look at that last sentence. The hypodermic syringes were as common as grasshoppers. We recently had a significant hurricane that caused lots of damage. Lots of devastation. It's a tragedy. But opiate overdose deaths. There's more opiate overdose deaths every day than there were deaths from Hurricane Harvey. The costs of this are greater than Hurricane Harvey. And we'll see that here. Look at these deaths. It's a national emergency. It's soon going to be a declaration of a national emergency. Look at these death rates and where these deaths are occurring. Well, that's right where we are. For the time span of 2009 to 2015, 7 years, there's been 304,000 drug overdose deaths. 128,000 of them were opioid. 128,000 is more deaths than occurred in Korea, Vietnam, Iraq 1 and 2, and Afghanistan combined. 26,000 more deaths. And if we use the statistics that look like we're going to be for 2016, 64,000 drug overdose deaths, we are at 90% of the deaths of World War II, just in that 8-year time frame. World War II was 5 years. So in an 8-year time frame, we're going to be at 90% of those deaths. Drug overdose is the leading cause of death for people under 50. That's, first of all, y'all, but think about that. We're not talking heart disease here. We're not talking COPD, diabetes, drug overdose. I know y'all are thinking, not here to study, not here to really learn a bunch of new things, but you have to. You have to understand some definitions. Opium is an old term. Opium is actually the direct product from the poppy plant. Morphine is a derivative. It is purified out of the opium. It was discovered in 1804. By the 1820s, it was being commercially produced and used. And of course, with the Civil War story, morphinism was a common situation. It was used commonly. Didn't need a prescription, didn't need to go to a doctor, didn't need to go to anybody, you just need to go to the store and buy it. Opioid. Now that's a term that you'll hear, and that's the term that you should use. You'll hear opiate, don't use opiate. And opiate is more specific. That relates to the direct products of the opium plant, the opium. Opioid means any substance that has activity at these receptors. And neuronal is italicized because for so long we thought that that's where these receptors existed, but in reality they exist all throughout the body. Fentanyl, it's a synthetic, is an opioid. It's not an opiate. So the definitions do have value. One of the things that has made this difficult to research is these opiate receptors comprise the opioid neurotransmitter system. And this transmitter system is ubiquitous throughout the body, does many things. Y'all are familiar with pain. Sure, it modulates pain, but it sure does a whole lot of other things. So where are we? Some definitions under the belt. Let's talk about where we're at. 2015, huge amounts being prescribed. 2016, huge amounts being prescribed. Now, the CDC says there were 61 million plus people had a prescription for opioids. SAMHSA, the Substance Abuse Mental Health Service Administration, says there was 91 million people had a prescription for opiates. Did they need it? Is that another example of the overprescribing? Let's see if we can get this. Look at the bottom line there. 599, 600 morphine milligram equivalents. That means every person in here can have 125 milligram hydrocodone, or 80 5 milligram oxycodone, or 250 micrograms of fentanyl. Now, I've used fentanyl a number of times, and I'll tell you, if any of us here had a 250 mic fentanyl injection, most of us would stop breathing. Now, would we recover from that apnea? Don't know. 250 mics of fentanyl one time, it's a big shot. For 2015, the statistics aren't out from the CDC for 2016, so let's look at 2015. You're familiar with the drug overdoses, the deaths. Then the opiates. Now, what about prescription? 38% is prescription, 48% if we include methadone, which we should. It's prescription. It's how you get it. This number here bothers me, and I'll tell you in a few minutes why. And look at this number right here. Nearly 500,000 ER visits because of opioids, drug overdoses, 500,000. Now, I want you to think this is really on the crisis of World War II. We're losing as many people, young, healthy people, to drug overdoses as were lost in World War II. Getting back to where are we? In 2015, 47 million people used illicit drugs or misused a prescription. SAMHSA says there's 20.1 million with substance abuse. And of course, now let's briefly talk about cost. SAMHSA, the government, federal government, reports out that the cost is $400 billion for substance abuse. Diabetes costs $245. Okay. Alcohol is $249 billion. And 3/4 of this is binge drinking. We're going to talk about that here in a minute. But 3/4 of the cost is binge drinking. And if we include tobacco, which the DSM-5 does, then it's another $300 billion. So if you look at the costs, $949 billion, $1 trillion. Our whole healthcare expenditure for the country is 2.5. We're spending 1/3 of it for substance abuse. If you look at the deaths, drug overdose, alcohol, and tobacco, we're losing more people from substance abuse than we are heart disease. Now let's get back to prescriptions, because that's one thing we can directly control, right? Y'all going to be prescribing very soon. How are you going to be prescribing? Well, let's look at how people are prescribing right now. For 2015, 12.5 million people misused their prescription. 2 million started. Let's look at stimulants. 5 million. 1.25 million started stimulant use. Recent study shows that less than 10% of stimulant users, prescription stimulant users, have an indication. 90+% of people that are prescribed stimulants don't have an indication to use the medication. Why is it prescribed? So, let's add up those numbers. 25 million people misused prescription medicine in 2015. There's only 2 states in our country that have more of a population, Texas and California. So that's more than 48 states' population, any one of those states. 5 million started. That's 2% of our population. If we have 2% every year, when is it going to be a critical mass? Now. 5 million initiated or started. That's a higher population than 19 states in our country. These are big numbers. And it's prescription. There's an extreme geographic variation. Remember that slide that showed deaths? A little bit of correspondence there, don't you think? Overprescribing has a geographic variation. So when non-medical people look at this, they scratch their heads and say, why? Why is there a geographic variation? Is there more pain in these states? Studies have been done to ask that question, and the answer is no. Top 10 CDC counties for opioid use per capita. Campbell County is just to the west of us. Of course, we're Claiborne County here. We're 7th in the nation. 8 out of these 10 counties are in our area. 8. This geographic prescribing, you can see it. Look right here. The geographic prescribing variation. And for 2016, it's worse. It's more dense. We're not making improvements. I put this in here. This is Virginia. Sometimes Virginia gets left out, but this star is us, right here. Okay? That's right where we live. Look what's right here. This is from Tennessee. Now, I know it's dated data. I couldn't find anything more current. But look at the spread from 2007 to 2011. The spread of basically overprescribing. Look how more red it's getting. Why is it getting worse when we're having an increased drug overdose deaths? Why is it getting worse when we're having more problems? Look at the clustering. Clustering of deaths corresponds to where the stuff is being overprescribed. This is something that has to be addressed. This just can't be going on. Federal and state authorities are beginning to address. 22 states now have prescribing laws. This is something you're going to encounter. I don't know if you remember the third slide. One of the reasons you're here is this is going to be defining themes for your careers. The rest of your time in medicine, you're going to hear about this. Some manner, some shape, some form. It's going to be laws. It's going to be liability. It's going to be deaths. It's going to be somebody watching what you're prescribing. And hopefully, most importantly, it's going to be you prescribing better, knowing how to prescribe better. These are commonly used. There's a fair amount of patients that do benefit, but we sure haven't been able to identify them. We've been overprescribing. And of course, we'll talk about it in a few minutes, why, some of the reasons. This is one way to classify opiates, and most of y'all already know this stuff, but I'm not sure who knows. So I want to be sure everybody's on the same level. Big difference between a long-acting opiate and a short-acting opiate. Their risks are different. We haven't appreciated that. And of course, especially for Dr. Colley, basic science. This is oxycodone. Look how similar it is to heroin, structurally. Fentanyl, synthetic. Here's morphine. We're starting to vary our structure. There's 20-some fentanyl analogs. We haven't seen all these fentanyl analogs. And that's not to say what other synthetics are out there. There are other synthetics. Now, you saw these two chemical structures. These two slides of chemical structures, I should say. This is what the body produces naturally. Y'all seen this before, beta-endorphin. Beta-endorphin's in the yellow. This is metenkephalin. This is pro-opiomelanocortin. Pituitary produces it. Basic science. This is the opioid neurotransmitter system. Has to work. Can't block it. But it's certainly being hijacked by these chemicals. And we're kind of complicit in that hijacking. Now, in general, we can think of opioids as natural, morphine, semi-synthetic, heroin. Heroin is a semi-synthetic. Or completely synthetic, fentanyl. Tramadol. That bottom right here, know this. You're going to see it. You're going to see it a lot. Mine will burn at your memory if you already haven't. But it's imprecise, very vague. Not a lot of good science behind it, but it's the best we have. This is how we compare the opioids. A few more definitions. I know it's early in the morning and definitions are tough, but these are things that you need to know. If you're going to be a radiologist, you need to know what tolerance is. You need to know physical dependence. I know radiologists, and I talk to them, and sometimes they have difficulty understanding these concepts. You just got to know it. The top, non-medical prescription opioid abuse. You see it abbreviated in the literature, MNPO. know this. This is something 10 years ago, we really weren't thinking of this. But in reality, this is a big situation. This is the misuse of prescription drugs, specifically prescription opiates. You're going to see the importance of that. Now, I've showed you about the overprescribing of stimulants, sedatives, benzos, opiates, but we've even overprescribed antidepressants. We got to get away from the idea of there's a pill for every ill. Now, there's lots of reasons why this is occurring. Some of it is illegal prescribing. Mr. Temple, in his great book, American Pain, talks about it. I've actually read it twice. But to me, when I look at my colleagues, when I look at what's going on, I see the overprescribing and the misprescribing, and I see that it's coming largely from not knowing. Maybe a harsh way to say it is cluelessness, but what don't we know? We don't know all these. Now, it's not a complete indictment of where modern medicine is right now, because some of these ideas, concepts, things we need to know, things we're going to see just here in a minute, we didn't know 5 years ago, let alone 10 or 20 years ago. Now, just briefly, where's overprescribing occurring? Everywhere. It's occurring post-operatively. It's occurring primary care. The surgeons, Annals of Surgery, this April, they've looked. And yes, 70% of what they prescribe is not even being used. That's overprescribing. By volume, the number one source is primary care, just because there is so many more primary care physicians than anybody else. And primary care people see patients with pain. The bottom thing, nearly 4 out of 10 patients presenting to emergency room misuse their opiate prescriptions, 40%. One thing hopefully today, everybody will understand the fallacy of the safety. There is no safety with these medications. If I talk to you about cisplatin or methotrexate, can I say those are safe medications? No. Those are chemotherapeutic agents. You have to understand opioids is the same. You'll see the term painkillers used. I don't let my patients use that word. The minute I hear a patient say, well, you know, hey, what about these painkillers? I interrupt them. No. The only way to kill your pain is anesthesia, local or general. Otherwise, the opiates may dull it for a brief period of time, but then you have to understand that there's risks and harms to take those opiates. And what are some of those risks and harms? Well, side effects, you already know that. Any medicine you prescribe can have side effects, including allergic reactions. But what about no functional improvement? The reason you're taking the medicine's not doing anything for. Studies have shown that for many chronic pain conditions, opiates provide no benefit. What if it makes other things worse? What if it makes depression worse? What if it leads to long-term opioid use? Well, that's kind of what we were doing, right? We were prescribing long-term. In reality, this increases your risk for lots of bad things. We'll see this in a minute. This is actually a harm. Long-term opioid use, for the majority of patients, is a harm, just like non-medical prescription opioid use. Now, exactly what does that mean again? That means patients are taking the medication differently than you prescribed it. They're crushing it and snorting it. They're shooting it. They're taking 4 or 5 at a time. They're taking it with other substances such as alcohol. This non-medical prescription abuse situation is leading to bad problems. With addiction, you can imagine if somebody's taking their medication, you know, they should take 4 a day and they're taking 10 or 15, they have a substance abuse problem. And they very well will overdose. So in general, the longer you use opioids, the longer, I should say, your patients use opioids, the more the risks. The higher the dose they're prescribed, the more the risks. So how much is too much and how long is too long? We don't know. Well, let me rephrase that. We didn't know this 5 years ago, 10 years ago. Nobody asked these questions. We didn't stop and ask ourselves, really, how much should we really prescribe? Of course, you already kind of know this with respect to antibiotics, right? We didn't ask that question either. Some recent data. This is from the CDC, September 2017. Risks and harms of opioids. Now, you look at the second sentence, second bullet point. It says 1% question. 1% comes from the pain medicine literature. 28% comes from everybody else. The CDC says 1 in 4. CDC says 25%. The risks of non-medical prescription opioid use. When you hand out a prescription, 1 in 4, maybe as much as up to 1 in 3 patients are going to misuse that prescription. You have to know that before you prescribe. You have to have that conversation with your patient. Now, the risk of 1 or 3-year opioid use by starting opioid. Long-acting. You give your patient a long-acting opioid, you run a much greater risk, 27.3%, of problems, complications, harms. If you start with tramadol, in the prescribing community right now, we kind of look at tramadol as not too bad versus hydrocodone, oxycodone. Well, actually, it's more than twice. Risk. Last sentence. Well, actually, let's look at any prescription, right here, any prescription of opioids. Anytime you write a prescription for opioids, you run a 6% chance of a harm. If you write it for more than 8 days, so any could be 3 days. Kentucky passed a law here this past year, 3-day limit for ERs. But if you write for 8 days, 13%. If you write for 1 month, 29%. It is exceedingly common for people to have orthopedic surgery, ankle fracture, shoulder surgery. They get a prescription for a month, and it's usually refilled once or twice. That's a great risk. In the bottom sentence, if your patient develops opioid use disorder, their risk of dying is now increased 20 to 30 times over. Does your risk for heart disease increase 20 or 30 times over if you smoke cigarettes? No, not that high. But yet, if you develop opioid use disorder, your risk of dying is much higher. Now, let's just talk about some of the outcomes. Short-term use. Maybe you show up to the emergency room, you fell in a hole, hurt your ankle, broke your ankle. You get a prescription for 10 days worth of hydrocodone. What's the outcomes? Well, one, you stop. You stop when the prescription is over or when you don't need it anymore. How often does that occur? We can't say. We don't have the data. You can progress to long-term use. 6 to 13.5% for 8 days or more. 31 days, a third of people go on to long-term use. And once you're at long-term use, your odds ratio let me find. Your odds ratio for opioid use disorder is 4.39. So long-term use is a risk. It is a complication that you have to tell your patient. And long-term use, 15 to 29% of the time, leads to non-medical prescription opioid abuse. They're crushing the pills and snorting them, maybe injecting them, maybe taking 10 or 15 at a time. And of course, that leads to overdose. overdose. Of course, there was 52,000 overdose deaths 2015. What about long-term use? We used to define long-term use as a year. Now we're looking at these complications actually develop in 90 days, 3 months. Some of these complications are actually present in 30 days. We don't know how much this is, but studies show that the majority, 50, 60, 75% of people who are on long-term opiates tell their primary care people they want to stop. They would like to stop. They realize it's not helping them, but they can't. Look at these risks. Once you reach this stage, you have a 19 times greater risk of progressing to heroin use. So if you're a patient who may have had bimalleolar ankle fracture with pins, has been on opiates for 2 to 3 months, they have a 1 in 5 chance, 1 in 4 chance of being here. And then once they're here, 19 times, 4% of these individuals per year go on to heroin use. This is just a repeat slide, same slide. I know how y'all feel about the slides. You've told me before, but to me, this is can't believe these harms that are coming from these medications that we haven't really considered. Now, are there risk factors? We know the risk factors for cardiovascular disease. We talk about them all the time: smoking, cholesterol, etc. What are the risk factors for addiction or substance use disorder? What's the risk factors for overdose? That's what's killing people. Look what's highlighted there. History of overdose. That's a risk factor. I'm going to see here in a minute how we just really haven't been thinking real well. This stands for Prescription Drug Monitoring Programs. This is the state programs. Every state now. Missouri has now committed to developing one. It's not in functioning order yet, but now all 50 states will have these programs. So on the prescription drug monitoring database, if there's more than four or more practitioners or 4 or more pharmacies, that's a risk factor for overdose. Do physicians think about this before they prescribe? We'll see in a minute. That's questionable. There is an inherent genetic variability to this whole situation. Of course, you already know this. You know there's genetic variability. You know with, say, for instance, the SIP systems for metabolism. You've had that. So what do y'all need to do? Well, I'll tell you right now, you need to be part of the change. You just need to. You need to help make this better. And you can do this. You can do this right now. You may know of a family member that is taking their medication. They take 5, 6 hydrocodone at a time. You need to step up and tell them, can't do that. And certainly when you start rotations, you're going to see this occur. And you can let your preceptor know. Dr. Smith, I think Mary here, she's taking more of her medication than she should be. I think this might be a problem. You can speak up. Maybe prevent Mary from having an overdose death. Just as an aside, naloxone is life-saving. We're not prescribing it enough. Now remember where I showed you that ER bottom thing, 160,000 per year are discharged from the ER. When people have an overdose, what are we doing? Are we plugging them into care? Are we taking care of them? No. One study shows 91% of people who've had an overdose get prescribed the opiates all over again. Hello? What are we doing? Somebody's had an overdose. Why are you giving it back? Another study showed 40%. Another study showed 60%. A half or more of patients who overdose, we're just giving them medicine right back. How is that? How is that thinking on our part? And look at this middle section right here. The majority of patients discharged after an overdose are not prescribed naloxone. You go to the emergency room, Maybe you report it to your family doctor. Well, yeah, I overdosed. We can't give them naloxone. Last week, MMRW, Morbidity and Mortality Weekly Report from the CDC, they did a case analysis of the carfentanil overdoses in West Virginia in 2016. And 20 patients who were exposed to this drug survived and were discharged from emergency rooms. Not one of them were discharged with naloxone. Not one of them were discharged and said, hey, you need to seek treatment. Here, call this clinic, call this person. We're not prescribing naloxone to people who are overdosing. This is not thinking. You need to be part of the change of thinking. This will be loaded up on the Blackboard site. This is a good little resource for not only talking with your patients, but learning what to do for overdoses. Now, how much is too long? How much is too much? All these questions you have to know the answers to. And in a very short time frame, really starting next year, you're going to participate in whether patients get prescribed medication that can do them harm. So you have to start knowing these. Back to what did Dr. Trzil say more than 100 years ago? Look at that first quotation. Look at the bottom. Journal of American Medical Association, 1888, time of Dr. Trzil. The article was How the Opium Habit is Acquired. The last sentence, physicians aren't responsible. Kind of seems like we've been doing or thinking this the whole time. But remember, it's more than you think, right? It's just not about prescription opium or opioids. It's also about heroin use. And heroin use can come from prescription opiate harm, complication. It accounts for half the deaths, slightly more than half the deaths. We need to figure out how we can identify these patients. Do they present with a medical complication, Hep C, endocarditis, an infected injection site with an abscess? You're going to see this in the emergency room. Are those patients going to be then referred for treatment? You may lance their abscess and send them on the way with a prescription for antibiotics. But then they may come back next month dead. Now, more than you think, right? Look at this. Of course, it's easy to understand 138% increase of heroin use in people that take their opiates however the way they want to. It's even easier to understand 100% use if they're taking their stimulants the way they want to. But look, there's even an increase of heroin use among binge drinkers. That's for a female, 4 drinks, male 5 drinks on 1 or more occasions within a 30-day time frame. That's binge drinking. That's 3/4 of the cost of alcoholism as a use disorder. Oh, but marijuana, you hear it's not bad, right? 50% increase of heroin amongst marijuana users. The progression to heroin. If you prescribe opiates for a long enough time frame and your patient goes on to develop non-medical prescription opiate use, and then subsequently they're part of the 4% per year that go into heroin, is that on you? Did you cause that? We have to prescribe better, okay? We just have to be doing better. Here's some of the ways to do better. Busy slide, and this isn't meant to be death by PowerPoint, and I know that there's a lot of stuff on these slides, and I've wrestled with this. I can't simplify this situation anymore. I can't make this into 1 or 2 bullets and say, okay, we're done, prescribe less, you're fine. No, that doesn't take care of the people who are starting with heroin use. That's not taking care of people that are being prescribed stimulants. So I just can't make this any easier. I can't simplify this down to a common denominator. That's what makes this whole crisis a problem. And if we don't know, if it's the crisis of not knowing all the details we need to know to prescribe better, it's also the crisis of not asking. You see that first paragraph, SGR, Surgeon General Report. Now, it's not in the executive summary, it's in the full book. Available online, you can download it free. You can get it shipped to your house free. Surgeon General Report says only 1 in 6 patients are asked. We're not even asking them about their alcohol use. And of that 1 in 6 that we bothered to ask, only 1 in 3 is actually told, please stop, change. You're heading down a bad pathway. You're setting yourself up for problems. We're not even, only 1 in 3 patients, can we bother to say, look, gotta stop. Just an aside, your second years, okay? Don't ask the patients about, are you taking illegal drugs? How are they gonna respond? No. Don't ask them about recreational drugs. No. I never do any drugs when I'm out on the boat. Don't ask the word illicit. Just tell them, just ask them. Tell me about any medicine or drugs you take. That's what I say. And you'll be surprised if they trust you, if you're not judgmental. They will tell you. We need to be educating, okay? This is something that you should be able to do real easy because we're pounding education into you, right? You should be educating your patients. Educating them about, well, binge drinking is a risk. It's a risk for substance use disorder. It's a risk for heroin use even, right? We help them understand about naloxone nasal spray. And there are some states now, you don't need a prescription. So if there's a family member that's taking 15, 20 Percocet a day, you can say to your family member, here, I went to the pharmacy and asked them for some naloxone. You need to have this at home. Because it could save their life. It's funny how some states are allowing this to be over the counter, basically, but yet physicians just don't seem to be prescribing it like we should. You need to manage patient expectations. You can do this. Help them understand there's not a magic bullet to make pain go away. And of course, we're trying to implement solutions for you. Your osteopathic training, your OMM, is an extremely valuable tool. Especially while you're here, maximize this. Right? I'm not a DO, so I'm not tooting my own horn. I'll tell you right now, when I see patients that come in with chronic back pain, I had a patient a couple weeks ago, he's had 2 back surgeries, told by his neurosurgeon he needs a 3rd. He came in with a cane, wobbling. He was weed eating for 6 hours. You know, why are you weed eating for 6 hours? But what did I have to offer him? Did I give him a prescription for opiates? Absolutely not. In fact, him and I had the chuckle about, I ain't going to help you, so you ain't getting them. He laughed and agreed. I tried to find a DO who can see him. Your OMM skills can help many patients with chronic pain. Chronic pain, the biggest category is low back pain. Oh, y'all can treat low back pain. You actually can treat it now. You can treat neck pain. You don't need to give a pill. But Dr. Still said that more than 100 years ago. Now, I'd like to take this time to introduce the next speaker. Mr. Temple wrote a book that I think all of y'all should read. He didn't ask me to plug it. Now, there's no financial thing here. Remember, put up on the front sheet there, no disclosures. But I've read the book. And the first time I read it, more than a year ago, I was like, what is this? Of course, naive me didn't know about this stuff. When I reread it, of course, the criminality stood out, but the tragedy stood out. So I encourage all of y'all, to read his book. Mr. Temple is a professor at the University of West Virginia in Morgantown, and he's going to talk to you about his experiences, his situation with the book, his observations, and I'd like y'all to give him a hand for coming all the way from Morgantown, West Virginia.